Welcome, everyone. My name is Dr. Jean Elwing, and I'm a professor of medicine and the director of the pulmonary hypertension program at the University of Cincinnati. We are all so glad you've all joined us. This is such an important topic. We're going to be talking about COVID-19 and coagulation. We're going to begin with discussion of possible mechanisms, followed by a brief review of what's going on in research in this area. And then we're going to touch on some things that you may not have thought about before, the long-term impact of this on our patients. We'll end with questions, and thank you so much for all of you who have sent questions in. We'll try to address those, and we're all looking forward to a very fun and informative discussion. So we have some great panelists, wonderful people who are here to share the information that we have about COVID-19 with you. And I'm going to ask each person to introduce themselves and tell what institution they work with. Would you start, Dr. Sahai?
Sure. Thanks, Jean. Hello, everyone. I'm Sandeep Sahai, and I'm a pulmonologist by training, and I'm one of the pulmonary vascular specialist, disease specialist here at Houston Methodist, Houston, Texas. And thanks for the CHEST for giving me this opportunity. I'm glad to be here.
Thank you. Dr. Kay?
There, my name is Dana Kay. I'm a pulmonary critical care physician currently doing more training in pulmonary hypertension at Mayo Clinic in Rochester, Minnesota, and I'm happy to be here.
Thank you for joining us. And Dr. Balasubramanian?
Oh, hi, everyone. I'm a pulmonologist by training, and I run the Pulmonary Vascular Center here at sunny California, UCSF Fresno. Again, glad to be a part of this discussion, and looking forward to a robust discussion ahead.
And Dr. Raleigh?
Hey, everyone. I'm Parth Raleigh. I'm a director of port program at Temple University Hospital, also the pulmonary physician and a lifelong PE learner. So here I am, excited to be with everyone.
And again, thank you guys for being willing to be panelists and help to share this information. So we're going to start about looking at what we know about mechanisms. And Dr. Sahai, I'm going to start with you. Can you tell us what we know at this point about the mechanism of thrombosis in COVID-19?
Sure. Thanks, Jean, for the question. So exact mechanism how the virus increases this, thrombosis is not very clear, but some of the studies which over the last 1 year have attempted to highlight the mechanism. And one of the important thing which has come out of this whole summary of research in this area, that as we know that this virus attaches to the ACE2 receptors, which are expressed on the pulmonary vascular endothelium, and then from that it gets internalized. Now, there are two ways. That one is the direct vascular injury which it causes, and the other way is that that injury leads to a robust immune response, and it could be either complement mediated. So there are sort of like a balance between in a normal pulmonary vasculature, there is a balance between the prothrombotic and the anticoagulant activities, and that gets imbalanced, and there is an inflammatory vascular injury which induces thrombin formation. There is downregulation of fibrinolytic pathways. There is downregulation of anticoagulant pathway, and combination of that and complement mediated, from which has been seen C5b to 9, that also leads to the vascular injury. One of the important studies which came out early on in this pandemic was published in Mayo Clinic. That was a very interesting study. They looked at the autopsy of COVID-19 patients' lung tissue and also H1N1 influenza lung tissue. And interestingly, they found that the people who unfortunately died with COVID-19 had pretty significant involvement of the pulmonary vasculature and what they initially termed it as endothelitis. So there is definitely some different mechanism involved, and what most of the researchers believe is ACE2 receptor mediated.
Okay, thank you. Yeah, I just think this highlights the fact that we are so underpowered for our understanding of this disease, and every little bit we learn and talk about and discuss is helpful. And all of us here are pulmonary vascular people, but none of us are endothelial experts or experts in this specific field. So just so you know, we're all like you, learning this as we go along. So Dana, I've got a good question for you. Tell me about how this affects the cardiopulmonary symptoms and systems, and what diagnostic tests can we use to assess patients with COVID-19 that we think have VTE in the clinical setting. Sorry.
Sure. So there have been a number of studies that have evaluated changes in pulmonary physiology in the setting of COVID-19, but specifically talking about thrombosis and pulmonary vascular disease leading to changes in pulmonary physiology. I think one of the more intriguing studies that I've come across was an observational study done by Dr. Patel and colleagues that was published in the Blue Journal this summer. And what they looked at was physiologic, morphologic, hematologic changes in patients with severe COVID-19. In this study, they not only evaluated laboratory markers of thrombosis and coagulopathy, which not surprisingly showed a hypercoagulable state in these patients, but in addition to a hypercoagulable state, they showed that there was evidence of widespread pulmonary angiopathy and increased physiologic dead space with the presence of dilated vessels and the peripheries of the lung seen on the CT angiograms, and also perfusion defects on dual energy CTs that they did. A lot of basically all the patients that underwent dual energy CTs had perfusion defects, and they were present in both dependent and non-dependent areas of the lung, which overall suggested vascular dysregulation. And if you want to go even beyond the pleura and talk about the myocardium a little bit, of course, there's a lot of evidence of acute myocardial injury that's seen in COVID-19 patients. And in autopsy series of patients in COVID-19, cardiomegaly and right ventricular dilation have been noted without evidence of coronary artery thrombosis, but rather just scattered areas of myocyte necrosis due to subacute pulmonary hypertension due to pulmonary intravascular coagulopathy, and just leading to diffuse myocardial stress and ischemia. There have been studies that have used echocardiograms and have shown RV impairment, and there's studies that have used cardiac MRIs, and they've shown more than 80% of patients with COVID have some kind of myocardial involvement as well, mostly inflammatory. So overall, there have been a lot of studies using different modes, different diagnostic studies, and I think overall they point to pulmonary angiopathy and thrombosis in patients with COVID-19.
You think that can help us understand why they have so many symptoms that we have such a hard time dealing with, their hypoxia that changes minute to minute, and their prolonged course? Do you think this could help us understand that a little bit better?
Absolutely. So, I think in patients that we see in the ICU or on the floors, we might just do a non-contrasted CT study and miss a lot of these other abnormalities, such as perfusion defects and perhaps some of the differences that we might see if we did a CT angiogram. So yes, I think kind of reviewing some of these studies, it leads you to pick tests that will give you more information in your patients with COVID-19.
Mm-hmm. I think so too. It's a very challenging disease to manage. And I think the more we understand about this aspect, the more we can understand about their hypoxemia. So Dr. Raleigh, I have a question for you.
Absolutely.
How often are these people really having VTE? And is it really different than our other sick patients, or is it just sick patients? And does it change from regions of the world?
Oh, that's an absolutely fascinating question. And I'll try to shed some lights with what we have learned from the recent times. I think I think one of the reasons for all of us are talking when we had a very early reports last year around this time, almost around this March or April time, where the first reports came out from the China and the European countries suggesting close to like as high as 50 to 60% of VTE events and in the patients with COVID-19. That got the entire pulmonary vascular community gave a different perspective of COVID-19 related vascular diseases. So I think that's where it started, a very high incidence of VTE events. If you combine with more an arterial event or a myocardial, other thrombotic events, the numbers were reported even higher, as high as 85%, which was staggering and unprecedented numbers. There were studies coming out from the French around this time, where they had the patients with COVID-19 ARDS patients and patients with without COVID-19 ARDS. And the incidence of PE was also 3 to 4-fold higher in the real world timeline. We also noted similar trends when we published our data from Temple. So yes, there was a lot of PE incidence-wise was reported compared to a non-COVID-19 related ICU patients. As the time moved forward, a lot of studies got published, and I think it was kind of very interesting to note what was the denominator of the whole VTE spectrum. Was it higher than the whole spectrum? And that's where things get a little murky, because earlier reports included a lot of a non-clinical relevant venous thromboembolism, where like a catheter-associated thrombosis. Some studies included isolated distal DVTs, isolated subsegmental PEs, which we don't even anticoagulate based on current chest guidelines. So depending on what your denominator pool is, your VTE incidence kind of varied drastically from a region to region. Mm-hmm. And now we have close to like 50 studies which have produced from different regions of the world, where they have looked at the VTE incidence. And what was also unique, just to add a point, that I think the entire community got caught by the VTE incidence, and there was very little publication about bleeding incidents, because having a VTE incidence always follows with our therapeutic intervention, or at least a desire to do the therapeutic anticoagulation. And there is still very limited data available on the bleeding events. So just to quote the most recent literature as it was published in Chest last month, where Dr. Jimenez and the group performed a very thorough, well-designed systemic review and answered some of the questions that I was referring to. Is the VTE incidence same in ICU versus non-ICU? And the answer was that ICU patients were much more high risk of VTE compared to non-ICU. Is VTE incidence same when you screen the patients prospectively versus you do a clinical decision-based screening? So when you do a prospective screening, and that's what was done in a lot of European countries, yes, the incidence of VTE was higher, but is that how we manage our clinical practice? Does it change clinical practice? Third question, which was very important, that the bleeding events. So yes, there was a higher incidence of a VTE incidence, but there was equally high incidence of bleeding events, unacceptable high rate of bleeding events when patients were empirically anticoagulated or even put on an intermediate dosing regimen. So I think when you put that into equipoise, I think what we have learned so far is kind of back to square one. And that includes myself, from what we started doing last March to what we are doing today, is I think we need more data. We need more robust data. And last to your question, is it the same across the world? I think as a part of that systemic review, we also did a subgroup analysis of geographic locations from where those studies were published from. So we divided into the European studies, which had like 62% of the studies included in our systemic review were from Europe. 20% was from the North America, and the rest were from the Asian and the other countries. And it kind of, the VT incidence reporting kind of followed how the COVID spread across the globe. So the highest incidence was in the European countries and the Asian countries, and the USA had the lowest incidence of VTE compared to other centers. But ironically, the bleeding incident was higher in US and Canada countries compared to the European countries. And we believe that because we know that there was a higher incidence of VTE, we anticoagulate a lot of patients a lot aggressively. That means we screen less, and that's why we have more bleeding, but the less VTE incidence. It's very interesting, a lot of association, but it kind of makes sense how we have practiced as clinicians.
No, that's, I think, very powerful information. The number of VTE events and the impact of management on that. So I think we can all agree this is a problem. COVID has effect on the small vessels in our lungs and our vasculature in general, and we have more microvascular and macrovascular events. So now we're going to move on to how we're trying to figure out how to manage this. So we're going to talk about what's out there in research, and we are not all inclusive. So everyone in the audience, we tried to pick what we felt would most impact your day-to-day management. So bear with us and forgive us if we've missed any important information. Please send us messages or questions in the chat, and I will be happy to go through those as we end with questions. So again, moving on to research, and I'm going to talk with Dr. Sahai again. Sandeep, can you give us an update on some clinical trials that are ongoing that you really think are important regarding the role of anticoagulation in COVID-19? And then touch on a couple of things that have been recently published, like the Inspiration study. I think we learned a lot from that. And talk about what's going on with the rapid coag trial. I want everyone to hear a little bit about that. So hard question.
Sure. Thanks, Gene. This study, let's talk about the JAMA paper published recently, Inspiration study. So the objective of the study was basically to assess the intermediate dose versus standard dose prophylactic anticoagulation. And the primary endpoint was a composite of thrombotic events, ECMO, oxygenation treatment, or mortality in COVID-19. This was done in Iran with multi-center trial, 10 academic center. I think the study design was pretty good. It was 2x2 factorial study design, and randomization and all the patients were treated with standard of care therapy. And basically they randomized patients into intermediate dose enoxaparin, which was 1 milligram per kilogram body weight per day, and versus the standard prophylactic dose. The total, I think they enrolled like 600 patients, and but interestingly, they did not find any difference in the primary endpoint, and which was composite of all the points which I mentioned earlier, like thrombosis, mortality, ECMO need at 30 days. They did not find any difference in that. So basically, one of the lessons we learned from this study was that intermediate dose anticoagulation was not any way better than a prophylactic dose anticoagulation in preventing, mortality or a need for ECMO or thrombotic events. Although study had pretty high mortality in both arms, roughly close to 40%. And also their standard of care treatment was a little different than what we use in the United States. So there are obviously certain things which we cannot really apply to our standard of care. But I think in principle, the concept of the study sort of highlights that probably doing intermediate dose anticoagulation is not going to really change outcome. The other one study which you mentioned was rapid. It's an ongoing trial right now. It's again basically in the patients, hospitalized patients with COVID-19. It's a pragmatic randomized control trial of therapeutic anticoagulation versus standard of care. And see, so this is an ongoing where they're using a low molecular weight heparin versus unfractionated. So it's basically in this there are 3 different arms. One obviously standard of care, other one is a low molecular weight heparin, and then unfractionated heparin. And the physician or the clinician, it's an open label study, but they have been given this. Because it's a pragmatic trial, so they've been given this sort of liberty to choose whatever based on the patient they want to use. Either they want to use low molecular weight heparin versus unfractionated, and they're using a little bit higher normogram if you're using unfractionated heparin. So this is an ongoing, and their primary endpoint is, again, it's a composite of with an elevated D dimer with ICU admission. This study is not in the ICU patients. This is those who are hospitalized but not in ICU, and need for non-invasive ventilation or invasive ventilation at 28 days. So we will certainly learn much more from this trial, but as of now, we don't know much information. So far, we don't have anything which could favor doing high dose or versus standard of care anticoagulation.
Very helpful. Does the inspiration data drive your management?
I think that trial, considering their background treatment, I think I cannot totally apply in my day-to-day care, but I think it does provide us very good information. Study is well done. Their study design is good. But I guess in there, and then, when we're talking about composites of ECMO, I think that each institute, even in the United States, each institute has its own criteria to implement ECMO and all these advanced care. So I'm not very familiar what they use in Iran. So those things can affect the judgment or
Sure.
drawing those conclusions into my practice. But certainly, if we just look at scientifically what they did, that was pretty decent to give the answer.
So at least a launching pad, right?
Yeah, it's certainly a launching pad. Yeah.
Yeah. And now, Dr. K,
Yes.
tell us some of the studies you think are helpful, and what do you think will guide us going forward, especially in our hospitalized patients?
Sure. So, when it comes to hospitalized patients and anticoagulation in hospitalized patients, I think one of the first studies that surfaced was a letter in the Journal of American College of Cardiology coming on a study coming from our colleagues at Mount Sinai in New York. And they did an observational study on patients with COVID-19, more than 2,700 of them. And what they noted was in 28% of those patients who received therapeutic anticoagulation, they didn't really notice much of an inpatient mortality overall. But when they looked at mechanically ventilated patients, there was a pretty drastic difference in mortality. 29% in those that received therapeutic anticoagulation versus 62% in those that didn't receive therapeutic anticoagulation. So I think that was one of the first studies that kind of caught everybody's attention. There wasn't much of a difference in bleeding events, but we have to say it was an observational study. No study is without its limitations. And of course, there was some survivor bias and some, missing data in terms of what anticoagulation agents were used and the duration of it, and whether or not those who didn't receive therapeutic anticoagulation received prophylactic anticoagulation. But nevertheless, I thought it was a very interesting study when it came out, and it led to a lot of other questions and other studies. So one being the very exciting study that's coming soon, hopefully. So the multi-platform randomized control trial that is basically a collaboration between 3 trial platforms, the ACTIV-4, the ATTACK, and the REMAP CAP trials. And they're working together with similar protocols and similar primary and secondary outcomes to answer the question of whether therapeutic anticoagulation in patients hospitalized with COVID-19 improves outcomes. And, I think once that study, the final results are not available yet, but just looking at the interim results that have been made available, it is very exciting, and it's very different compared to some of the other studies that have been done throughout this year on anticoagulation in hospitalized patients. Gina, if it's okay, I'm going to actually spend some time talking about this multi-platform randomized control trial.
I would love that. I think our audience would too.
Yeah, because I think, when the results become available, it'll be a study that everybody's going to be talking about, and it can be potentially management changing. So what this study looked at was patients hospitalized for COVID and whether therapeutic anticoagulation, so low molecular weight heparin or unfractionated heparin at a therapeutic dose, whether it improves outcomes. And so what they looked at was organ support-free days. They looked at the incidence of major hemorrhages, HIT, mortality, length of hospitalization, the events of thrombosis and multiple organs, and also intubation. And the way they set out the study was they stratified the patient population into either moderate state, and those were patients that were hospitalized but not ICU level. And of those patients in the moderate state, they further split them up into based on their D-dimer level. So whether the D-dimer was very elevated, above 2 times the upper limit of normal, or whether it was elevated but below the 2 times of the level of the upper normal. And then the other group that they is the severe state group, which is the critically ill patients in the ICU. And overall, the 3 platforms show that moderate state patients in both D-dimer levels saw a benefit from the use of therapeutic anticoagulation. So their organ support was less frequent in those that received the anticoagulation. Their mortality was a little less as well, 5.7 versus 7.7. And there wasn't much of a difference in terms of major bleeds. Now, looking at the severe state patients, those who are critically ill, they noted actually harm in when using therapeutic anticoagulation in that population, which is basically the opposite of what the study out of Mount Sinai showed. And they actually had to stop recruiting in that arm because there was an increase in mortality, 35% versus 32%. There wasn't much of a major difference in bleeding, but I thought that was very interesting. And now the question that this really brings about is, well, what do you do with your patient that starts off on the floor and then gets upgraded to the ICU? Do you do anticoagulation or not? And, in that study, what they did is for those patients, they continued anticoagulation if they were floor patients and then became critically ill. And in that subset, they actually showed benefit with the use of therapeutic anticoagulation. But it makes you think, well, what if they hadn't continued it when they became critically ill? Would the benefit in the moderate state group be even better? Mm-hmm. And so very exciting study. We were all looking forward to the final report so we can really pick it apart and kind of look at the details of their data. But we're all going to be keeping an eye on that.
Oh, yes. Thank you very much. And I think that was really powerful information. And all of this stuff is rolling in over this year. And it's so, it's fascinating to keep up with, but also difficult. So thank you for that beautiful summary. So now I'm going to ask Dr. Rowley a very tricky question. How do we put what we know, what we just talked about? These people are at high risk for VTE. We have some but limited data. But how do we put that into an active guideline to use that's a living guideline, because we keep getting more information? You're on mute.
That actually is a fantastic question. And I think it's the right question at the right time, because I was fortunate enough to be a part of a CHEST Society COVID-19 VTE specific guideline panel, which was developed in the middle of a COVID pandemic. So a lot of credit to the CHEST leadership and pulling the team together. But I would take a moment to how to kind of how we all came together, and then what are the things that we achieved actually changed a lot of practice. And I think the first, there were 13 panelists across the globe. And I was the least expert in that, but just an example about overall the VT, there were like 2,500 common publications among the authors. So I think I did that and I presented the jury, and I still say that, because that even though there are guidelines and there are expert opinions, because there was lack of evidence, but I think there was a lot of stuff that we adapted from what we knew about a VTE in a non-COVID VTE setting. I think the whole goal of the panel was, what is the evidence that we can use from a non-COVID VTE setting and apply and recommend in a current guidelines? And what are the areas that we need more data to improve upon? Commonest burning question that we all get asked, that should I change my D-dimer based on anticoagulation regimens. It's just an example. We all had that question, but there was not even any data to suggest that D-dimer-based anticoagulation practice should change anywhere in the literature. So when panel had all these questions, we came up with 13 PICO questions, and we could not fit into D-dimer into that category solely because it's never been studied even in a non-COVID VTE setting. So, but then we came up with the 13 questions that where there was an evidence, where there was some recommendation that we could make. And the panel came up with, within a 2 months time, very robust way of a systemic review, following very closely the PRISMA guidelines. We came up with some form of evidence-based recommendation. If somebody reads the guidelines, I think one of the highlighting, the way these guidelines were different from standard VTE guidelines, because each problem at hand, we tried to divide the group, as I think all the panelists were referring to, into an ICU population and a non-ICU population, because very early on we realized, as our panelists have mentioned, that patients in the ICU group are a separate subset in terms of VTE risk instead of bleeding risk versus a non-ICU patient. So each guideline or each guideline statement has a separate recommendation for ICU and a non-ICU patients. Some of the highlighting things that we often get asked that I would like to bring, I think that's worth mentioning, is one of the burning question is that DOACs. Can we use DOACs in a hospitalized patients with VTE in a COVID setting or not? And one of the things that I would like to bring it up is that DOAC studies in a non-COVID ICU setting excluded the protease inhibitor drugs. So it excluded the patients who were on antivirals. And because we know that the remdesivir and a lot of antiviral agents are the first line treatment to treat the diseases, the panel felt very uncomfortable in recommending DOACs in the patients with VTE with COVID-19, even in a prophylactic dose, even in a critically ill patients, and the patient, because everybody is going to be on some form of antiviral agents. Remdesivir was particularly one of the exclusion criteria when the large randomized trials were done with the DOACs. So I think the things that we brought out, no DOACs. Second, should we use aspirin or antiplatelet agents or any other antiplatelet agents as a VTE prophylaxis agents compared to the low molecular weight heparin? And answer to that is also no, because we know that as a primary preventive dosing, antiplatelet agents do inferior performance compared to low NOx or unfractionated heparin. We do not know whether adding an antiplatelet agent to low molecular weight heparin is better than low molecular weight heparin alone, which is currently being studied in a randomized trial. So not as an isolated agent. Third thing that we get asked is that should we do an intermediate or prophylactic dose regimen? And I think panel kind of had a little bit of discussion, very heated discussion, as we all can have our opinion-based discussion. So what we end up doing that for ICU patients, because we knew that there is a higher risk of bleeding, we actually using a little stronger language on saying recommend against, versus on the floor patient, we say we should consider. So if you read the guidelines, yes, it does say no for both of them. But if you look at the level of emphasis that we are putting in because of the inherent nature of the bleeding risk of the population, the guidelines are actually recommending to do more studies. And finally, one of the points that I want to bring it up is a post-discharge prophylaxis. So the post-discharge prophylaxis, the panel felt very comfortable using non-COVID well-randomized trials, which is Mariner trial or Magellan trial, which had a post-hoc analysis looking at the role of DOACs in preventing of VTE incidents post-hospital discharge. And it was a futile point, meaning that yes, it does decrease slightly reduction in the VTE incidence, but that was met with increased risk of bleeding. So unless we have identified a patient with a very low risk of bleeding and a very high risk of VTE in general, panel is also recommending against the DOAC use. So I guess I'll stop there. These are just some highlighting features. I'm sure I gave you some enough information that encourages people to read the guidelines, but I'm sure we'll come back and refer when we have more questions from our audience.
Well, I think I have a question from the audience, and thank you for sharing. What kind of scoring system can we use to help guide us?
Yeah, so I think what was published in the Mariner trial was an improved score system.
Anything else
So
too?
basically, yeah, and I think it basically identifies the patients who are low risk of bleeding, meaning the patients who don't have terminal cancer, who don't have a high risk of tendency to bleed. So I think identifying a very low risk patient is very important in determining who should be considered. Dr. Jimenez and the group from REAT registry in their one of the COVID VT studies, they I think brought up a very important point about what's frailty score on the patients, because I think once the patients get discharged from the hospital, are those patients getting discharged to a nursing home where they're not going to be moving? Are those patients are completely back to normal and they're going to be out in the community and walking around? Or those patients are still going to be on quarantine and limited in terms of mobility and they're still on oxygen. So I think that is something which is new to COVID, that mobility is a big factor. So I think improve score with in mind that what this patient is going to do once they go home for next 45 days. I think you may want to take into consideration deciding what kind of anticoagulation you want to send them out on. So I think I would add a mobility performance score on top of the improved score, particularly for COVID-19.
No, that's great. And I think that's something also we've seen that's so different than our flu patients. These patients, when they're sick for a long time and they have high risk of VTE. So we have to behave a little differently, at least from what we believe right now. So more to come though on that in terms of the active force studies for outpatient. So now you guys haven't heard from Dr. Balasubramanian, and you probably thought I was ignoring him, but I wasn't. I was saving some hard stuff for him. So we talked about high risk. We talked about what studies we thought were important to share, but I want to ask him how he thinks this might affect the landscape of pulmonary hypertension, pulmonary vascular disease going forward.
Thank you. I was just, thank you, Gene.
He was practicing. So
no, I was listening
ready.
Intently.
Yeah.
And I was kind of getting a little thing. I was wondering whether I needed prophylaxis myself, because I've been sitting around listening to all these eloquent conversations.
I know. That's what I was saying. They thought I was leaving you out, but I was keeping a special question for you.
So, no, thank you. Thank you once again. And sorry if I come across like a psychologist amongst all these fantastic factual discussions that have had. There is, as you know, in fact, thanks to Parth, he shared a very nice phrase with me, which is COVID venous thromboembolism issues are almost, what we know about it is almost certainly uncertain. Okay, so there is nothing we really know very well, and that part is factual. Okay, so, and the other issue is interestingly, despite the plethora of studies that Sandeep, Dana, and Parth have gone through, some of the salient ones, there is a relative deficiency of any long-term kind of studies as to what actually is happening in the long term with these patients as far as outcomes, whether COVID survivors or COVID-associated VTE survivors, what is the true mortality? In fact, there is considerable controversy even with the true incidence and prevalence of venous thromboembolism in this particular situation. As everybody has alluded to, there is a significant amount of variation. Now, when it comes to things that are unclear, so one is the true incidence of venous thromboembolism between COVID and non-COVID patients. And number two, the role of anticoagulation, therapeutic versus prophylactic versus intermediate anticoagulation. And these, hopefully, we will know with time. Now, coming to the actual long-term complications, there's only one study that is out there, and it's hot off the press from February. This is from Spain, which really talks about it's an observational study looking at about 100 patients. And they found that many of the documented cases of PE occurred in the absence of DVT and are located in the more peripheral pulmonary arteries. And therefore they were kind of postulating the unique PE phenotype characterized as immunothrombosis. Now, in this particular study, the frequency of PE, 64%, was markedly higher than the previous reported real-world VTE studies, where it ranges from 25 to 38%. The majority of complications, both whether it comes to death or major bleeding, occurred in the first 30 days. And what they concluded was ICU admission, thrombocytopenia, and cancer are risk factors for poor prognosis. So with that, I can say that there is hardly any other data looking at long-term sequelae or long-term influences on venous thromboembolism due to COVID, and would love to see more studies, and I'm sure there are many more coming.
Thank you. Thank you. I think this is something we've got to be mindful about. These people are going to come to see us, right, BJ? We're going to see them in clinic.
Absolutely.
I don't know if any of you guys have, but we have long COVID clinics now. Who on the panel has long COVID clinics at their institutions? So at least two of us now. And by the end of this year, probably all of us will have that. So we've got to be thinking that sometimes you have an event, a venous thromboembolism, and you have long-term consequences. And it has to be on our list of things to look for when we see these people. So important information. So now we're going to change gears a little bit. And I want to take a few minutes and ask Dr. Raleigh to talk to us about how the guidelines and the studies have changed our regimens of outpatient prophylactic anticoagulation and inpatient anticoagulation. What are we doing differently now than we were at the beginning of the pandemic? How have we changed? How are we actually adapting? And are we doing a good job or not? And how many of these people outpatient are actually having VTEs? Do we know anything about those patients? So a lot of questions.
Yes, so I think I'll start with the outpatient world, because I think this is where I think I was referring earlier with our CHEST guidelines, that as a panelist, what we felt. So there are, just a backtrack to that, there are 75 randomized controlled trial. I think Dr. Beccadelli published a review article where he actually showed how many randomized controlled trial, and we are talking about a good real randomized controlled trials with COVID VTE. So there are 75 trials. I think Dana brought it up, the largest one, but there are 75 total, looking at every single thing that we touched upon, and we'll have those answers hopefully soon. But I think going back to the, outpatient VTE world, and how do we optimize that? So I think there is only one paper that I'm aware of came out of UK Royal College, Imperial College of London, where they had 500 odd patients who were discharged with COVID, and they followed up to 45 to 60 days, which is what a DOAX trial did, a randomized trial did. And their incidence of VTE was not higher than what we know in a medically ill patients who were discharged, which is somewhere close to 1.6 to 2% post-discharge VTE in a medically ill patients. So that trial paralleled the incidence rate. They also noticed that people who were sent out on DOAX had a higher bleeding rate, which is also close to 3.2%, which is exactly was showed in Mariner trial, which was exactly what's shown in a post-hoc Magellan trial. Sorry, those crazy
Magellan, yes.
Magellan, right. Thank you.
Yeah.
Thank you. But yes, exactly. So fortunately, that data matched a very huge randomized trial, which are close to 12,000 to 15,000 patients. So I think I think out of everything that I feel confident that we can stick to those randomized trial and use the improved score and maybe adapt a little bit of mobility score to decide your anticoagulation. Same thing will happen. So the only difference is that if you decide to put them on anticoagulation, patients who are getting out in the community who are not on antivirals, those would be a good candidate to go on the DOAX. So that subgroup of the patient who are not on remdesivir anymore, and we don't have an outpatient remdesivir yet, I think if you diagnose somebody as an outpatient VTE with COVID, those patients, we can stick to our original guidelines of doing an anticoagulation with DOACs for 3 months. So I think that is the only group where I feel confident, or the panel CHEST guidelines supported, that you can consider to use DOACs in that group.
Okay.
So I hope that I answered one part of the question.
It does.
And I'm going to go back to that second part of the question, is that how does our practices evolve? And I think I'm going to refer back to what I think Diana brought it up. And I think I think we had that question about D-dimer, how that D-dimer drove us all crazy. And I think it certainly drove me crazy. So I'll have a little bit of perspective on that. I think if you go back to the original literature published from Tang, they only showed that the D-dimer is a marker of disease severity. D-dimer was associated with a higher mortality. D-dimer was associated with a higher DIC and a bleeding events. I think original studies never showed that D-dimer should lead to the change in our anticoagulation practices. I think because we are so familiar with the D-dimer values, I think it was us, and us includes starts with me, that we all got excited to understand that D-dimer is higher or is changing, and we need to adapt a changing anticoagulation prophylaxis. I think the guidelines kind of brought it up a very evidence-based discussion and ask us to take a step back and say, please trust on what we already know, meaning that don't use D-dimers in an hospital setting patients. Given that, I think we also, if you talk, learning from a hematologist, we also learned that D-dimer has a direct inhibitory effect on fibrinogen also. So D-dimer may present a spectrum of the patients, meaning that it could be a part of procoagulant state, or it could be a part of consumptive coagulopathic state. And I think that's where we are getting burned down, that once the patients are in the ICU setting or hospitalized 5, 7, 10 days, they are going into that critical ill, sick patients and doing unappropriate anticoagulation on them. I think we have been burned more. So I think I was not following the CHEST guidelines. I think 6 months ago we all were in commotion, but I think year after the initial COVID, I think I stick to the guidelines. I find a reason not to anticoagulate, and I find a reason to screen the patients, clinically indicated screening, CTA, bedside echo, focus. We all are ultrasound savvy people nowadays. So I think that's where the emphasis is focused on diagnosing and finding an appropriate direction to anticoagulate the patient. So I'll stop there. I'd love to hear what our panelists think about that. But
yeah, exactly. I was going to ask Dr. Sahai. So Parth mentioned 3 months with a DOAC for an outpatient with VTE because you're not using remdesivir. Tell me how long you're managing these people that have a VTE and they're critically ill and they remain debilitated. And, many of them remain positive with their COVID testing. Who knows what that means exactly, but how long are you going to anticoagulate those folks?
Yeah, thanks, Parth. That was pretty detailed and thorough discussion. And thanks, Jean. So one of the things which I have learned from these different society guidelines and everything is that there is a central message and there is a common message, which is for post-discharge patients, if they are high risk for thrombosis and low risk for bleeding, you consider anticoagulation. Now, the question comes at what's the duration? Now, if suddenly someone has a documented thrombosis or PE or DVT while they're in the hospital, then obviously you would continue them as a standard protocol for 3 months, like Parth mentioned. But the question is, if you were doing the standard of care anticoagulation and there is no documented thrombosis, then how do you want to monitor them post-discharge? And I think that's where most of the society guidelines sort of vary. And then it goes to, if the patients have risk factors for thrombosis or they're low risk for bleeding, then you may consider using anticoagulation. Like, for example, ACCP CHEST guidelines actually does not recommend, if the patient is discharged from the hospital and there is no documented, they don't suggest to use anticoagulation. However, International Society of Thrombosis and Hemostasis says, their panel actually said consider 14 days. 50% of people voted to consider for 14 days and 20% said in high-risk people. So there is you can see there is a variation. Then there was a global COVID-19 thrombosis collaborative group, which suggested 45 days considering high-risk population. Now the question is, how do you want to define those high-risk people? So like Dr. Raleigh mentioned, high-risk people, those who are immobile, they're still having symptoms, they're persistent, probably those kind of people, they're aged, elderly, or elderly people, and the history of cancer. And so it's sort of very variable, and I think it's more of an individualized approach, but they're certainly not recommending blanket anticoagulation for post. I think that's the central message I can learn. I have one of the questions in the audience. Someone is asking, if you, Jean, won't mind me.
Oh, please do. Please do.
It's asking about the thrombolytic therapy in COVID pulmonary diseases. And I think that's a very interesting question. To be honest, if you look at Dr. Raleigh, who's been author on the CHEST guidelines, they actually recommend against using it. And there is really no data to support that. Is that correct, Dr. Raleigh?
Yes, I think empiric use of anticoagulation, because I think there is one trial going out, and there was a case series published of 3 patients, I think of University of Colorado or some center that I don't recollect, where out of 3 patients in a dire need, physicians used TPA, and 1 or 2 of them survived and 1 died. So that led to whole notion of this microthrombosis as a last resort to treat TPA, which is completely lack of evidence based. TPA, just to remind everyone, is a $10,000 drug. So and it's a brutal drug if used incorrectly. So yes, absolutely, panel was against that. And I think panel also answered is, when would you use TPA? So I think the answer was simple: go back to the old CHEST guidelines and use for the patients with the VT, with the massive PE, or the ones who are at the verge of hemodynamic compromise. And also and don't only look at the RV, try to make sure it's an acute RV or a chronic RV, and same stuff that you do in a non-COVID setting. But yes, interesting enough, there is a trial going on. You looking at the tenecteplase, which is slightly different than alteplase, at a multi-center site in the patients with submassive PE in COVID-19 as an investigation trial. And I think that's what is only recommended thing is that be a part of trial to study that particular drug, because it's a push dose instead of an infusion dose, quick action, and a short half-life. It's the same drug that was used in the Python trial. So I think that's one of the exciting trials with the COVID-19 VT on horizon.
So not something we need to jump into. We really need to understand this. Our patients have bleeding risk, and we can't just blanket give them lytics, not 1, cost, and 2, efficacy, and 3, risk. Right?
Absolutely.
So there's some important questions coming in, and I want to have Dr. K comment on a new press release and what she thinks about it. And then Dr. Balasubramanian is going to talk to us about CTED.
Yeah, absolutely. So I think the question is, should we change our strategy of anticoagulation in non-ICU patients based on the trial I just mentioned, the ACTIV-4, ATTACK, REMAP, CAP trials that are coming out? And I think that's an excellent question. I'm personally someone who would like to see it peer reviewed and see it in black and white and look at the data myself, but I fully anticipate it to be management changing. And, I think as medicine goes, a lot of people are going to start giving anticoagulation to non-ICU patients with COVID. And after a year or 2, we're going to reevaluate the data from there. And then, either it's going to back up the original study or it's going to completely change things 180 degrees again. But, for now, I would say I personally am going to wait for the peer review finalized report, but I fully anticipate it to be management changing for a lot of people.
No, I agree. But I am looking forward to reading it in print.
Yes.
So Dr. Balasubramanian, tell us what you think about CTED, CTEPH in this population.
Yeah, thank you for that question. Actually, I saw that question in the question box as well. So unfortunately, it's a very reasonable and a very good question. But again, this is only time will tell some of the answers. As we know from the prior study, the PENGO study from 2004, which was published in NEJM, which estimated about a 3.8, 3.9% of CTEPH in patients who have had pulmonary embolism in 2 years. Then there is a much more recent study, 2018, where from Switzerland, again, these are all non-COVID patients with pulmonary embolism, where they actually estimated a much lesser incidence of less than 0.7% in these patients. So there is considerable variation in the incidence of CTEPH in the non-COVID population, in the general population, so to speak. So as far as COVID's influence on coagulopathy, which Sandeep and others went through, it is going to be very interesting to see over time as to what is the impact of COVID-induced coagulopathy, whether it increases the incidence of CTEPH over time. And some future longitudinal studies, I'm sure, and registries will throw more light on this particular aspect. As far as CTED, absolutely zero studies out there from what I know, and especially when there is considerable discussion and controversy around even defining CTED. As you know, people talk about post-PE syndrome, delayed resolution of embolism, in situ thrombosis, and persistent shortness of breath. How do you define CTED itself is relatively arguable. But anyway, I'm sure we will get answers with time.
I think this is going to be what we learn next. Huge amount of information is going to come to us because this is a big bolus of patients that have had PEs and maybe missed and, maybe stayed at home sick. We don't know. So I think more to come on that topic. And Sandeep, can I ask you about using antiplatelets? Patients ask me about it. People ask the question. So tell me when and where and how we could use antiplatelet therapy, if ever, in our COVID patients.
Actually, I think most of the time as clinicians and physicians, we wonder, especially those who stay at home and they're not getting admitted to the hospital, on those mild cases, should we be considering any antiplatelets and all? Actually, there is no evidence, and there is, from the guidelines also, it says no, not to use any of the antiplatelets. And D-dimer should not be used as Dr. Ali mentioned earlier, that it's more like an inflammatory marker than just indicating thrombosis. So the short answer is no. I'm not sure if there were any long-term trials or anything going on right now focused on this, but the answer is no.
Okay. So when my patients ask me, I have to tell them, no, we just need to manage you symptomatically for your COVID, unless you get sick and need to come to the hospital. Fair?
That's fair.
Okay. Are there any other burning things you all want to share with our amazing audience that have asked so many great questions? Anything from the panel? Okay. I have been so impressed with you guys. You have shared so much information in such a succinct and efficient way. I really am proud to be part of the team. And I thank you guys for doing this with me. And thank you, our global audience, for being with us and asking such great questions. We appreciate all of your time and attention.
Thank you. Thanks, everyone. And thanks, everyone around the world joining today.
Yeah, and some of us, like Dr. Smart physicians, like Dr. Sahai and I'm not smart. We all are on Twitter, so please join us. And please keep coming with the questions. We'll make sure that we get our panel's opinion and maybe try to answer some of the questions there we could not hear. So please look out for us, and we're happy to connect again.
Wish to thank CHEST and the organizers for actually putting this wonderful thing together, because it was a much needed discussion, and I'm sure I benefited a lot from this discussion myself. Thank you.
Absolutely. Thank you to CHEST and everyone who participated in this discussion. That was much needed.
Yes, I agree.
Thanks, everyone. Thanks, CHEST. Thank you.
Thank you.